Well, thank you, Matt, for inviting me. I better turn this on, eh? Okay. Thanks for inviting me. You know, Aspetar really has become part of my family here in Doha, and I'm so pleased to be invited to speak to you today. And hopefully I've got it at a level that everyone gets something out of it. I just wanted to let you know that this is going to be more of an acute injury talk rather than a chronic injury talk. It's just too big. I'd be happy to come back, Matt, and talk more about the chronic overuse type syndromes with respect to this as well. But this is what we see here at Aspetar as well, so hopefully we'll get something useful out of it. Just a little bit about me. Actually, Craig Tanner was just saying, I didn't even know you were here. So I thought I should give you a little bit of a little overview of who I am. So I'm actually from Canada. I'm from this little place called St. John's, Newfoundland. It's on the east coast of Canada. I haven't lived there for an awful long time, but it's still my home. You can see it's snow there. There's not snow there all year round, contrary to what you may think about Canada. It's actually quite beautiful in the summer, and it's quite beautiful in the winter as well. It's right on the most easterly edge of Canada. I did my training actually in Calgary and was a consultant there for many years at the Alberta Children's Hospital. And this, to me, is one of my other homes in the world, in Canada, and still have great fondness for that place. Like Craig, I lived and worked and trained in Melbourne, Australia, and did a pediatric orthopedic fellowship there, which was one of the fantastic formative times. And I was a consultant there as well for 6 months, where I really learned a lot about the Australian psyche. And Craig, I even watched the movie The Castle, which we can talk about later. If you know any Australians, watch the movie The Castle, and you'll learn a lot about the ins and outs of that country. I then went on to Starship at Children's Hospital in Auckland, and I know Celeste and Lisa have spent some time in Auckland, and with one of my mates there, Stu Walsh, who many of you may know from the sports medicine circles. So it's a small world here in sports medicine and orthopedics, and this is just the two hospitals. And Halifax was my most recent place where I was a consultant in the east coast of Canada, closer to home, and a fantastic place. Guy Brasseau was one of my partners there, and I'm happy to have Guy here with me in Doha as well, so it continues. And here we are, Sidra. Inshallah, we will have Sidra open. We're working on, just a little update for you, we are working on opening the little building here on the right, which is actually not that building, not that little. This is the outpatient building. I think it's 5 or 6 floors. Some research labs on the top, and the rest is outpatient. We also have some ORs in there. So our plan of activation is to see our first patient there in May. So phase 1 is finally starting, and so Dr. Popovich and I have had commiserated about the problems and joys of opening a hospital. So I might tap your brain to get some more about that as we get closer. So an overview of the talk today. We're basically going to look at just really a broad stroke, looking at aspects of pediatric injury patterns, particularly things like, how kids are different than adults, whether they're athletes or non-athletes actually, bony problems versus ligament problems, physeal injuries or growth plate injuries, and their potential to remodel. These are all important things that make them better to work with and sometimes harder to work with than adults. We're going to look at some shoulder injuries, particularly with the clavicle and proximal humerus, elbow injuries, and some wrist injuries. And again, these are more of the acute variety, and many of these make up the clinic, which I do here at Aspetar. And for those of you who don't know, I have done a clinic here, which was really started through collaboration with Dr. Popovich and Dr. Landreau, and now with Dr. Farouk Hamad here at Aspetar on Mondays. And so if you have anybody who you would like me to see, I'd be happy to do so. I had lots of inter-institutional collaborations so far. We've been doing that since April, and I think it's going pretty well. So kids are different, aren't they? I mean, they're not just small adults, is the cliche that we say about children. In orthopedic and musculoskeletal injuries, we typically get fractures in children rather than ligamentous injury. So when you talk about sports injuries in children, you're really talking about fractures for the most part. The bone is the failure point rather than the ligaments in the younger kids. And so we don't see as much in the way of ACL ruptures. We see ACL avulsions. We don't see as much of chronic ligamentous strain. We see epiphysiitis. We see physeal and growth plate problems. So they're quite different. And the bone is the failure point rather than ligaments, and that's something which will be pervasive through this talk. They're easily fractured, but when they do fracture, it's often with low energy. So a child falls playing football, going in for the goalpost, as Celeste was just telling about earlier today. You know, it might not actually cause a fracture in an 18-year-old, but in an 11-year-old, their bone is so soft it's easily fractured. But a very small injury with a quick rehab time and quick healing time, and the healing time actually is mostly related to the fact that the bone is so vascular. But with all the blood supply going into the bones, it's almost like Swiss cheese, you know? You get an arteriole here, and you got a bunch of holes in this bone. Very easy to fracture. Growth plate injuries, which most adult orthopedic surgeons, I think, who've forgotten a lot of their pediatric stuff, are quite concerned about dealing with growth plates. And I always think, boy, I'm concerned about dealing with what you deal with, because the growth plate actually is so forgiving and allows the child to deal with deformities that you wouldn't be able to deal with in an adult. And also the speed of healing is so much better than an adult because of these growth plates. So I think they're a good thing. Certainly there's pitfalls you have to watch out for. And remodeling a bone. So the capacity of the bone to change from a deformed entity to something that's straight, just by virtue of biomechanics and by the pathophysiology, the physiology of the growing bone. So we talked about the physis or the growth plate being a good thing, but you also need to be, fearful of it in some ways too. You have to really keep your eyes open for potential problems, because an injury to the growth plate, you can see this one here on the distal ulna, an injury to that growth plate, probably don't see one here, eh? Injury to that growth plate can actually cause a growth arrest, so it can stop the longitudinal growth of the bone. And if you have paired bones like these two, where one stops growing and the other one doesn't, you can see that you get an overgrowth of one versus the other, and that can cause problems, impaction injuries. And I've got a case to show you about that. The different fracture patterns we talked about, and remodeling. And the remodeling of the bone really depends on a couple of factors. Age. The younger you are, the better capacity you have to remodel a bone. What bone it is, where it is in the bone. We'll talk a little bit about that. So here's a 12-year-old male who had a fall in the outstretched hand playing football. It's swelling around his wrist, no deformity. It was very tender at the distal radius. Actually, it was tender right around here. Anyone have an idea of a diagnosis? Just fire something out. Is it too early? Okay, someone said Salter-Harris 1. Yeah, I mean, that's exactly what it is. The tenderness was very focal, right on the growth center itself. And we've got bone on either side, and this, you can see this line, which is often mistaken for a fracture for people who aren't used to dealing with children's injuries. This line is actually made of chondrocytes. We'll talk about that. And it is a point of failure. When you go from an area of soft material to a point of hard material, that's a point where you can have a failure, whether it's iron or whether it's bone. So let's talk a little bit about the anatomy of the growth plate. I think it's important just to get that out there, because a lot of the cases we'll talk about will have something to do with this. Very simply, the bone is made up of a couple of key areas, key regions. The epiphysis is usually at the end of the bone and typically associated with a joint. So if you have a fracture through the epiphysis, you may have an incongruity of the joint, which we might need to fix as an orthopedic surgeon to avoid a risk of long-term osteoarthritis. We also have a metaphyseal region here, which is a very vascular, spongy type bone, and the diaphysis, which is more the shaft, okay? In between the epiphysis and the metaphysis is the physis itself, and I've really exaggerated it into its many levels, and we'll talk a little bit about those zones. And there's these connecting ligamentous structures called the perichondral ring, which keep it all together. And the physis that we talked about contributes to longitudinal growth. So if you have a problem with the physis, if it's a complete arrest of the physis or destruction of the physis, well, it just won't grow in length. If you have a partial destruction of the physis, say on one to the radial side or something, you'll get a deformity in addition to shortening. And that's probably a bigger problem than just having a complete physeal arrest. So here's the physis exaggerated again. And it's important to know these, just a little bit about the zones here, okay? Try not to zone out while I tell you about the zones. This is the most important zone. It's called the germinal zone. This is the starting cells, the chondrocytes that start from the epiphyseal, from the epiphysis itself. So a fracture that kind of goes through this zone is going to affect the growth plate's function, because these starting cells then proliferate. They multiply into this zone here. You can see the columns of these chondrocytes or cartilage cells. Then they hypertrophy, they get bigger. And then they start to ossify. They start to get calcification, which makes it a harder material. So we were talking about fracture biomechanics and stuff. If you had a fracture through the physis, where do you think you might get a fracture? Just knowing what you now know about the physis. Within the physis, where do you think you'd see it? Any ideas? Provisional calcification? Yeah, in fact, it's just before that, isn't it? Because that's where the change in material happens. What do you think about the risk of growth arrest with a fracture through that zone of hypertrophy or just before the zone of provisional calcification? High or low? Low, I see a low, I hear high. Low? Why low? Why low?
Because the origin is higher.
That's right, yeah. So the germinal zone is where it all starts. So if you don't disrupt the germinal zone, your risk of growth arrest is actually quite low. And thankfully, most of the growth plate injuries we see in children don't involve the germinal cell at all. Not just because I'm Canadian and proud of the fact that this classification came from the Hospital for Sick Children in Toronto, Bob Salter and Dr. Harris. This is an important classification to know, okay? And this is the only one I'll talk to you about this whole talk. Salter-Harris classification is six groups, and it all depends on where the fracture line goes through the physis and out through the bone. So this is type 1, as you rightly pointed out, is Salter-Harris 1 distal radius through that zone of hypertrophy. And the risk of growth arrest, you guys think, is low. Okay. So here's a Salter-Harris 2, probably the most common fracture we see in athletes, pediatric athletes. What do you think? Risk of growth arrest? It's important to know because, you know, whether you follow this person and just say, okay, you're finished, halas, or you need to come back for multiple appointments to make sure that the growth plate doesn't shut down. This has a resource allocation as well, and also, anxiety. It's anxiety producing for the family. Type 3, how about this one? This one's fracture through the growth plate and out through the epiphysis. Risk of growth arrest? Yes. High. And there's another problem with this one. What's the other problem? Where's it exiting into the joint? Yeah. So if it's exiting through the joint, it's not displaced. Well, fine. You need to watch it to make sure it doesn't displace. But if it exits out of the joint and it's displaced, then that's something that you might have to get an orthopedic surgeon involved with to put the joint right to avoid long-term problems with osteoarthritis. And also, it also increases the risk of growth arrest. You can imagine if things are not lined up, then you're going to get a bony bar that goes across there. So anatomic alignment is important in these ones. Salter-Harris 4, I didn't have one of the wrists, very uncommon, or of the upper limb to have a Salter-Harris 4 in anything. So I've got a distal tibial fracture over there. What do you think the risk of growth arrest is here? I'm not going to be able to teach you guys anything. You know it all. This one is important. Type 5. So this is a crush injury, okay? What do you notice about this X-ray that on the left? Have you seen that before? Yeah, well, I don't. This is also the same X-ray as a Salter-Harris 1, but the mechanism of injury is so much different. A Salter-Harris 1 has a low energy, typically get twisting or a fall in the outstretched hand. This is more a crush, a direct impact where you smash that whole physis and you destroy the germinal cells. And we might have one of those cases a little bit later. So the risk in this case, even though it looks the same, is high. So how do you know? This is discouraging, isn't it? How do I know? Am I going to tell every patient that has a Salter-S, well, I know you've got a risk of growth arrest and deformity and surgery? It's really by the history, isn't it? The mechanism of injury is what you go by, more so than the actual X-ray appearance, because they can look exactly the same. And it's only later on, when you see the onset of growth arrest, that you really make the definite diagnosis. So it's hard to make that diagnosis right at the beginning. It does behoove us to at least do surveillance of physeal fractures for a little while after that we see them. And the last one is one that was added a little later by Mercer-Rang, I think. And this is the risk of growth arrest secondary to a perichondral ring fracture, so the stabilizing collagen-based structures on the outside. So the risk of that one, what do you think? This is usually like a shear, like someone gets thrown out of a vehicle. You wouldn't see this too much in a sports setting, but thrown out of a vehicle and just sheared off the skin, everything right down to the growth plate. Yeah, I know. It's terrible, isn't it? Risk? High. In this case, it's high because, even though you don't have the germinal cells involved, you've basically cleaved off this entire thing, and you almost make a connection between the two bony sides. So it's actually high in this case, and because it's so lateral with that arrest of the physis, actually can get a very, very strong deformity very quickly. Let's get into another case. So there's an 8-year-old boy who I haven't seen much acrobatics here in Qatar. I don't know if there is an acrobatic thing, but there's competitions and things like this in North America. And so we see a lot of these budding acrobats. And so this 8-year-old boy, can you imagine, was at a circus camp and missed the trapeze grapple. He caught with one hand only and then proceeded to twist all his weight into a valgus stress, one-handed. Thankfully, he had a net and everything, but he didn't actually fall. He's a very strong boy, despite the fact that he injured his elbow, and they managed to get him. He came to the emergency department, marked pain and swelling, and really unable to move his elbow. And he came with these x-rays. Any thoughts? His pain is just around the elbow, kind of lateral aspect of the elbow. He's holding it like this. He doesn't want to move it. Let's name there's a fracture there, I'll tell you that. Which bone? Which radial head? Radial head? Perfect. So yeah, it's kind of subtle, isn't it? But there's your fracture there. What type of fracture is that? 2. Salter has 2. Salter has 2. Do you think that has a high risk of growth arrest? We said no, right? And not likely. Although this kid had quite a bit of force involved, so it's something we still want to watch, but likely not. There's another thing that helps us to determine whether there's a fracture, even if you didn't see that fracture, something called the Sale sign. And whether it's a supracondylar fracture or a lateral condyle fracture or a fracture of the proximal radius like this one, anything that has a fracture where blood goes into the joint can cause this Sale sign. And can you see that line, almost like a black triangle there at the back? And that kind of looks like a sail, don't you think? So it's called the Sale sign. And it's basically the lifting of the capsule and some of the periarticular fat off the bone. We also see it anteriorly as well, but the anterior Sale sign is very nonspecific and not very sensitive because there's a lot of fat in the front of the elbow joint, and so it can often be factitious, So, but if you see a Sale sign, look for a fracture. Okay, so it's an important thing. So always look for the Sale sign. If you see it, look for a fracture. Occult supracondylar fractures can be picked up just by finding the Sale sign and doing a good clinical exam. So proximal radius fractures typically involve the physis or the radial neck, and they're actually pretty common, usually kids greater than 9 years old, and they can tolerate a lot of angulation actually. Maybe not as much as this one you can see here, but because of the remodeling potential of the bone, if you're less than 10 years old, you can accept up to 45 degrees of tilt. Isn't that amazing? We'd never be able to accept that in an adult, would we? And in even younger kids, less than age 5, you can accept up to 70 degrees. So that's a lot, and it will reliably remodel and do fine. Older kids, of course, the older you get, the less remodeling potential. Now you have less, but still 15 to 20 degrees, that's a lot of tilt. This one, of course, 75, no matter who you are, we have to fix that. And typically we would do that, try and stay out of the joint. Anytime you get into a joint, you risk hemarthrosis, stiffness. So we try and stay out of joints where we can. Typically, the way we would do this actually is to put a K-wire up right in here, under this, and lever it up and flip it right onto there while an assistant's doing some varus stress. It's a nice little technique called percutaneous K-wire leverage. It works great. But you get a little nerve around there that sometimes gets dinged, so you have to be careful. So with this kid, what do you need? I mean, I think with athletes, you want to make sure they get back to sport as quickly as possible. But you also want to mitigate that by not sending them back too early and then setting up this cycle of inflammation and arthrofibrosis and more problems. But in this case, because of the Physeal fracture, it heals very quickly. After about 2 weeks with just a splint, you can take them out, start range of motion exercises when they're clinically non-tender and have got their strength reasonably back, then they can go back to full sport. There is a risk of growth arrest. You do have to keep an eye on things. But and I usually see them at least 6 months afterwards, and typically at a year as well, just to make sure that the physis stays open. In children, unlike adults, if you have a radial head fracture, we don't take it out, okay? Growing kids, that bone can just slide down and disrupt the wrist mechanics at the distal radial ulnar joint. So we leave that head in and reconstruct it at all costs. Thankfully, Salter-Harris 3 and 4s are not common in that end of the bone. Let's do another. Hope you don't mind, I'm doing a lot of cases here. I started to put this together. I was getting bored. So I thought, we got to do some cases or else we'll all fall asleep. So a 14-year-old ice hockey player had a valgus stress while going into the boards. Marked pain and swelling, unable to move his elbow. Here's his x-rays. What do you guys think? One thing's pretty obvious. Dislocation. Someone said dislocation. Yeah, absolutely, dislocation. What else is going on here? Who wants to tell me what else is a problem? See anything else? What's this thing? It could be a lot of things, couldn't it? Someone said capitellum. You know? This is trochlea here. This is capitellum. Capitellum looks okay. What should we see at this age? This is a 9-year-old, right? 9-year-old. 14. Oh, sorry. Yeah, of course it's 14. So the elbow ossifies. It's it's another scary thing, for the uninitiated, because the elbow doesn't look like an elbow until age 12. Up to that point, it's a bunch of little ossification centers, and they all come at different times. The capitellum, for example, you just start to see it at about age 6 months to a year. And then I have a mnemonic in my head, which I can't say out loud, but Crito, the capitellum comes at 1. The radial head comes at 3 years old. I can only remember with the one I can't say. So I'm just going to, email me, I'll send you. But basically, these centers come over the course of the kid's life. And the medial epicondyle, which is one of those centers, should be there by about age 7 years. So you should see that ossification center there by age 7. Up to that point, it's made of cartilage. You can't see it on an x-ray. Do you see a medial epicondyle anywhere? Right. I don't see it. So maybe that's a medial epicondyle. And in fact, someone did a closed reduction just with some gentle traction. Couldn't stand looking at it in that position, and I would certainly agree with that. How did they do? What do you think? Do you like what you see? That joint's pretty distracted. After we do a reduction of a joint, we look for what we call a concentric joint reduction, which means that one joint surface and the opposing joint surface are congruent. You have this with kind of like a rock in between. That's not going to be good for the long-term health of that joint, and nor for this person's hockey career. So we need to do something about that. And in actual fact, this is an absolute indication to operate on the medial epicondyle. And it's actually a very controversial bone in my world as to whether you should do anything with it or not. But we did. I had no trouble making this decision. But even if it wasn't in the joint, we would have fixed this. This was an athlete who needed to get back to sport very quickly. And to leave this to heal on its own would be fine if they're non-athlete. Particularly if they're in a throwing sport, though, where you have a lot of this, valgus stress gets put onto the elbow. The medial epicondyle has a huge role because your flexor pronator wad actually attaches there as well. So you restore strength. You allow them to get early range of motion by fixing these things early. And just use a simple screw. The big issue with this is there's a big structure around here which we don't want to injure. Anyone know what it is? Right on that medial side. Ulnar nerve, exactly. Robert, I think, said that, right? So 3 months later, it's completely healed. Patient's been back to sport now for a little while. So these fractures really occur as with respect to a avulsion, so pulling the bone off with a valgus force to extended elbow. Usually in the 10 to 14 age group, as the child's elbow becomes the adult elbow is when we typically see these fractures. I said that was around age 12. 50% of them will be there with an elbow dislocation. So if you see an elbow dislocation for any reason, say someone at Aspire dislocates their elbow, they come to you quickly and you say, okay, I'll just put that in the joint. Fine, you could do that. Just make sure you do a good x-ray afterwards and really look, do I have all the pieces? Are they all in the right place? If you don't see the medial epicondyle, look for it in the joint because 50% of these will have it. And then the controversy, fix or not fix. I said athletes, if it's displaced at all, we fix it. Non-athlete, we think about it and we talk to the family. But if it's more than 5 millimeters, I typically fix it because I think they get their strength back quicker and get back to normal activities quicker. Fixation, even with fixation, you still need to give them a period of rest, 2 to 3 weeks, and then you can get going with it. And you can't get them back to sports until it's healed and non-tender and pain-free. Elbow dislocation is actually not that common in kids. Like I told you before, bone is the point of failure rather than ligaments. And ligaments are what's injured during dislocations of joints. But as the patient goes from a kid to an adolescent to an adult, that's when you start to see the change in the fracture epidemiology. So you go from a fracture to ligamentous injuries. So below age 10, you're looking for fractures. So if you think it's dislocated, it's more than likely there's a fracture, and that's what separated the two ends of the bones. So look for that. But over age 10, you do tend to get elbow dislocations and other joint dislocations. Posterior lateral displacement is most common, and you need to look for bony fragments, as we said, treat with gentle traction. Here's one, a 10, you can't read that. It's a 10-year-old equestrian. So this girl was, in Calgary, horse riding is huge. Horse riding is big here too, I know. And so there's a lot of young kids who are wanting to be the Olympic medalists. And so she was thrown off her horse during jumps and ended up falling at very high energy with an outstretched arm, twisted, and then went into severe hyperextension and underwent this dislocation. I don't know if you can notice, and I hope no one's squeamish here, because when I went through my case files, I don't like showing stuff off the internet, where I like to find my own cases so I can tell you the actual stories that happen. When I went through my case files, I never collect elbow dislocations because it's such kind of it's just an elbow dislocation. But this one, if you can notice here, here's the skin. Where am I here? Here's the skin here. And then skin here, and this bone is here. Anybody squeamish? So this is what happened to her. So this is a sports injury too. And you can see here, this is the median nerve and brachial artery right here, tented over there. Amazingly, she did really well. We treated it as an open joint dislocation. It was irrigated, debrided multiple times. And she had a scar, but it took her about a year to get her range of motion back, but she pretty well got it all completely back and had a transient median nerve palsy, which got better. And she went back horseback riding. And we never had any fixation first nor last because, again, it was the bony surfaces what held it together. And we got her moving early. So a 70-year-old gymnast injures her elbow during a vault. You know about gymnastics, right? Vault. That's a horrible. I was looking at some videos of this last night when I was sort of thinking about this case. And my son does gymnastics at a very low level. I'm treating lots of gymnasts and have over the years. And they put an awful lot of force. I mean, they really make their upper limb a weight-bearing joint. And so we have to think of the upper limb as a weight-bearing joint in sports like gymnastics. So again, same story, valgus compressive, but compressive stress this time during her vault, and severe sudden onset of pain, unable to move her elbow. And she presents with these x-rays. Any takers? Anybody see anything? A little more subtle than the other one. I'm trying not to give you obvious ones. Anybody see anything? How about the AP? AP is the easiest one to see it. Humerus, radius, or ulna? Let's start there. Humerus, okay. How that? Anyone know what that's called? It's the lateral condyle. So in the distal end of the humerus, you've got a medial condyle and a lateral condyle. So the lateral condyle is the one that's more likely to be fractured. Of course, if you get a fracture through here, above the condyles, we call it supra, or above the condyle, supracondylar. And this is a very weak spot here in the olecranon fossa, where it's kind of almost like wafer thin. So in addition to this, though, what you don't see is the rest of the bone down here, do you? All you see is the capitellum, which I told you ossifies and is visible at about age 1 year. And everything else is you don't see any of it because of the age of the kid. But this is what's really there. That's all cartilage. And so the fracture actually goes through the cartilage and into the joint. And there's actually an intra-articular component to this. So these ones, if they're displaced, need to be fixed for several different reasons. 3 weeks post-injury, this one wasn't really, if you look at that, I mean, this was aligned really well. I think most people would say, let's see how it goes. It really was essentially non-displaced. So we put it in a cast, but we follow it very closely. And the thing about these is when you get them back, you can't just look at it through the cast. We could barely see it when it was nothing on it. You have to actually take the cast off to get a good x-ray. And then 3 weeks later, we did that. We had followed it actually weekly, and it progressively displaced. And here we are. It's not going to heal. And these ones are a high propensity to non-union based on the fact their blood supply is not very good. Blood supply really only comes through bone, and most of this entity is cartilage. And in the front, it's all joints, so there's no blood supply there. The blood supply just comes in from the back through the triceps muscle, and you fractured through that. So the risk is high that you'll have a non-union. So we took this to the operating room. And the first thing we wanted to do was see, well, could we actually just do this very percutaneously? Like I said, I want to stay out of the joint if I can. So if the joint is lined up reasonably well, maybe we can just close the book and hold it and give it some stable fixation to get that to heal. And this is an arthrogram, so we put some dye in the joint, and it shows us that cartilaginous portion. It's kind of like what you would see on an MRI. And then we actually just put our screw right into this osseous fragment here, close the book, and heal really nicely. And we got him back reasonably quickly, although he lost a bunch of weeks because we probably should have just done it in the first place. So lateral condyle, second most common elbow injury after supracondylar. I'm actually not talking about supracondylars today. It's just too much. Ages 6 to 10, valgus or varus force, both could be valgus compressive or it can be varus tension force. And most of the fragments are non-ossified. So you need to infer this injury. Sometimes you don't have that nice metaphyseal piece, that bony piece you saw there. Sometimes just a little sliver. And so you really have to do a good clinical exam. And if they're tender right there, really scrutinize those x-rays and maybe get different films or even an MRI to help you. It's not good to miss these things. Under 2 millimeters displaced, we typically just cast it for 3 to 4 weeks and get them back to their activities. And if they're more than a millimeter displaced, so 2 or more, then we will either do a percutaneous fixation like I did or an open reduction channel fixation. And the risks are high because of the blood supply. Non-union, avascular necrosis, losing the blood supply to that fragment. Stiffness, any joint you open or any elbow injury gives you stiffness. One of the hardest, as many of the therapists will know, it's one of the hardest joints to rehab. And in the late cases where you get this progressive valgus deformity with the non-union, you actually get traction on the ulnar nerve, which causes a neuritis, and you actually get a clawing of the hand from a tardial ulnar nerve palsy. So don't miss these ones. We've actually picked up several here at Aspetar, just in the clinic. Not from here, from outside. People have gone somewhere, it's been missed. It's a subtle injury, and we've helped them. So it's a good thing to have in your brain. So this is an 11-year-old female, following the outstretched hand, playing ice hockey. And she's not from the Calgary Hitmen, but this is kind of the A-level team where if you're pre-National Hockey League in North America, this is the place where you'd end up before you get into the big time. What do you guys think of this? This is a sports injury, right? 45 degrees, distal radius and ulnar fracture. We need to do a closed reduction on this, don't we? We need to at least get this thing lined up. We can't leave this person like this. They'll never do anything again. So just want to give you some brief principles of closed reduction. How do we get that bone back on with just using some basic, it's really first aid, to be honest. And this is a typical appearance that we get in kids and adolescents, where you get this bayonet deformity, where you get complete displacement, and it's almost like the knife on the top of the gun or on the bottom of the gun. We call it bayonet apposition. They have a very strong periosteum. Children, unlike adults, have very strong periosteum, and it ruptures with great force, but then it kind of often gets flipped into the space. So if you just try and pull on it to get it straight, like you could do in an 80-year-old, then it doesn't work, because you've got this big flap of periosteum stuck in your way. So you need to get it out of there. And here's how you do it. You actually recreate the deformity. And so it flips it out. And I usually tell the residents that if you don't make the nurse go weak in the knees, then you haven't done your job. It has to go way back. And that's the only way it'll come out. You extend almost 90, and you flip it out. A little bit of traction in to disengage the fragments, and then reverse the forces. And this nice thick periosteum on this side actually becomes a stabilizer. You could almost go without a cast if you've got this on. So in fact, we often just treat it with not in this case, but nowadays we're treating more and more of these fractures just with removable splints. And the randomized control trials have shown that kids do better with that. But it is time to put on a cast. If you're going to put one on, if this is your fixation, you should do it right. It needs to be molded well, 3-point molding. And there's an index called the cast index, which helps you to see if you've done a nice job, where in the lateral plane, this dimension should be less by a lot of this dimension. And if you can get that, that means you've molded it well, and your risk of redisplacement of the fracture due to poor cast is less. So here's what we did. We tried that. What do you guys think? Good job, bad job? Just life? Bad job, bad job. This is what happens. I mean, especially if you're working in academic institutions where you have trainees doing mostly this stuff. And in actual fact, in this age group, that would do just fine because of the remodeling potential. But because the family was so talked up that it had to be perfect by one of the trainees, we kind of were behooved to bring them to the operating room. We did do it. But this would remodel perfectly. Bayonet apposition, no angulation. This age group be fine. But we brought him back, and we got it better. Is it good enough? Absolutely. It doesn't need to be perfect, because you know already that the PHYSIS and the remodeling potential of these children is such that you shoot for perfection, and all you do is increase their risk. So you need to know what the acceptable limits are. So what is an acceptable reduction? Well, it depends on age. So the younger it is, the more you can tolerate what bone. So some bones are have more tolerance to deformity than others, where in the bone, and whether the fracture involves a joint. And we talked about that. If it involves a joint and it's displaced, you need to do something. So if you look at the distal radius, for example, a metaphyseal fracture, if you're less than 5 years old, you can accept up to 20 degrees of angulation, right? That seems like a lot, doesn't it? In fact, I would accept more, probably around 30. And 5 to 10, less than 15, so getting less. And 10 to 15 years old, less than 10. In an adult, you can't accept really anything. You really need to have a good, and that's why we do a lot of percutaneous K-wiring and open reductions in adults versus kids who can reliably remodel. As long as there's about 2 years of growth remaining, you have good remodeling capabilities. So if we look at distal radius fractures, the metaphyseal fracture is the most common. Out of all the fractures that we see in children, in athletes, the distal radial metaphyseal fracture is the most common upper limb injury, right? So you need to know something about it. I see some nodding. You've all seen it, probably. Many people have seen it. They're often incomplete, which is good, because this is almost, I talk to people, this is like a bruise on your bone. It doesn't need a whole lot. It's going to heal quickly. Like this one here, where you can see it's like a wrinkle. And I could tell people it's a wrinkle in the bone, you know. Thankfully, you just have wrinkles here, not in your face, is my usual stupid joke that I give them. 3 to 4 weeks in just a wrist splint. You don't need a cast for this. Just a wrist splint, just to make them feel good. 3 weeks, they're done. If it's completely displaced, you do need to do a closed reduction and cast, like I told you, a complete fracture. And those can get out of there whenever you see good bony healing, somewhere between 4 to 6 weeks. The thing is that we see, and you have to actually make sure you tell the family, is there's a risk of refracture. And they'll always blame you if you don't tell them, right? You took me out of the cast, I went and I broke it again. Usually it's the same thing that they did before to break the cast, which breaks the limb, which causes the fracture. But the reality is the bone is weaker, not right at the fracture site, because that's got a big load of callus. It's just adjacent to the fracture site. Again, it's that change in material from something wide to something narrow, and it fractures right at the junction of those places. So I tell them about a 5 to 10% risk of refracture. So let them know that. Tell them you can fix it if they break it again. So I have a 14-year-old boy that slid into first base, baseball player, wrist hyperextension injury, diagnosed as a wrist sprain in the emergency department. He had no x-ray, no tensor, he just had a tensor bandage. It was painful about 3 weeks. He sucked it up, he was pretty stoic, and went back to sports soon after and didn't have any problems. Until a year and a half later, he started to get an insidious onset of ulnar-sided wrist pain. Now he can't throw a baseball. He's their pitcher. And this type of activity, he just can't do it. When he goes back for the windup, just gets that pain right there. His examination shows he's quite tender, right at the dorsal ulnar carpal joint right here. Anyone knows your anatomy, that's right around the area of the triangular fibrocartilage complex, TFCC, the meniscus of the wrist. And if you check his range of motion, he can flex to 100, which is good, but he can't really extend that much. Actually, sorry, it's the opposite. He can extend, but he can't flex that much. And here's his x-rays. What do you guys think? C'est normal? Any takers? Ulnar impaction. Yeah, you're going right to the end of the scenario, which is good. So if you look at actually the ulna, you see it's a bit longer than the radius by that much. So this is an ulnar positive, it's positive ulnar variance, and there's some impaction going on here. Do you think he had that before? How would you know? You could x-ray the other side. In actual fact, the other side, he's negative in his ulnar variance by about 2 to 3 millimeters. So this is abnormal for him. And if you look at his radial inclination, which should be normally about 22 degrees, it's on measuring 10, so that's not correct. And look at his the tilt in the lateral x-ray of his joint, which should be about 5 to 10 degrees volarly tilted, is tilted 15 degrees dorsally. What do you think happened to this guy? Growth arrest. Here's a CT scan showing a bony bar across there, bony bar there, and a bony bar there. And the physis that remains open. So here's something you had to progress. He had an injury, probably a Saltaris 5. And then a growth arrest. Didn't bother him. Got better. It only started to hurt him when he got the secondary problems associated with it. And hence the plea to keep an eye on these things. And he needed a big surgery to reconstruct this. We had to shorten his ulna, and we had to do an epiphysedesis, so we had to take out the growth plate of ulna so it wouldn't come back. Because we can't make the radius grow anymore. And then we had to realign the radius, and we brought it back to this. That was an awful lot of surgery for something that could have been prevented. So physeal arrest is uncommon in Salter-Harris 1 and 2, but as you guys told me, in 3 to 5 it's very common, and 5 is probably the highest risk. Early detection is important. If we found this very early on, and we saw, okay, he's got near complete physeal arrest, well, what I'm going to do is I'm going to make it complete. So I'll drill out his physis at the distal radius, and I'm going to drill out the ulna too. So yes, the whole limb will be a little bit shorter, which you wouldn't notice. But as I tell the parents, you're only as short as your shortest bone when you have paired bones like this. So keeping them level is much better from a functional point of view. And nobody's ever needed to have a lengthening for doing stopping the growth there, because it's typically in this age group. If you have less than 50% of the physis involvement, so that bony bar is only like say 30%, then you could take it out, and there's a chance you might get the bone growing again. But if it's more than that, then you should just shut it all down. And the problem with differential growth in paired bones is there, an ulnar impaction syndrome, as Celeste had mentioned. You want to correct the deformity if they have functional problems or if it's a progressive problem. You don't correct it just because they have a growth arrest, but if it's progressive, if they get a functional problem, then you do it. We're coming to the end, guys. So you got a 16-year-old boy slammed to the wall playing squash, painful wrist, x-rays negative, went back to sports after 4 weeks. Here's his x-rays. What do you guys think? Scaphoid, right? Scaphoid fracture. Unfortunately, these weren't his x-rays at the time of the injury because he never got any x-rays. So this is a year and a half later, and now he's got a non-union. This is one of those ones where you get the falling outstretched hand, you get some radial-sided pain, they kind of shake it off, undisplaced scaphoid fracture, kind of grumbles along, they see somebody call it wrist sprain, and then it gets better when the inflammation settles down, they go about their business. And it's only later on when the non-union really starts to develop and things start to be more mobile that they get pain. And unfortunately, you can't leave a non-union alone because the natural history is not that good. So in these cases, we need to do an ORF and bone grafting, which we can be doing. It's very successful, but it's better to get it beforehand. You can do these things percutaneously now. These are very prone to non-union. You've got one major nutrient vessel which comes from distal to proximal. So if you get a fracture through the waist, then this whole thing becomes avascular and can get avascular necrosis and non-union. And the other problem is they're very hard to see. Here's this one. Here's the x-ray. You could say it was this guy. Didn't see anything. Do an MRI because you're clinically suspicious, because you've done a good clinical exam which includes snuff box tenderness, but that's not enough. So if you do that on yourself, it hurts anyway. Distal pole. So pressure on the distal pole, do both sides. And then axial compression of the thumb. Those are the 3 tests. If you got all 3 of them, pretty sure you've got a scaphoid injury. You should definitely get advanced imaging if you don't see it on x-ray. You can see the fracture here very well. And so you treat that on a thumb spica cast, 6 weeks, it'd probably be healed. If you wait, now you've got a non-union situation. Much longer to get back to sports and things after trying to treat a non-union. Last couple. 13-year-old male, smashed into a goalpost, isolated injury. People don't like these ones. I've seen many of these here at Aspetar. Isolated injury, neurologic neuroimpulsive presence. Pretty obvious. Surgical neck fracture. This is the shoulder. Okay? Who would operate on that? Anybody? Huh? Dr. Landreau? The rotator cuff is fine, Dr. Landreau. Where are you? This was treated in Sling with pendulum exercises quite early. And here it is 5 months after the injury. The physis here at the proximal humerus is very active. And it stays open till age 18. You got tons of time for this to remodel. To put that ice cream back on the cone would likely take an open procedure through a delta pectoral approach. And the few studies that are out there, and some personal experience, they just don't rehab as quickly, and they can get stiffness. And making an x-ray look pretty is not always the best thing for the patient. And look at this one. And here it is, 5 months later. And this is remodeling. Lays down bone on the compression side and removes it on the tension side. And a year later, this will be almost straight. But in the meantime, the patient's playing sports, doing everything, not stiff. You've been able to rehab them from about two weeks or even earlier post-injury, and they do much better. I think that's the goal, get them back as quick as possible. Fracture remodeling, osteoclast, take the bone away, osteoblast, put it on there, periosteum adds in, better in the plane of joint motion, so the shoulder moves everywhere. It's got the highest range of motion of any joint, so this also has the highest remodeling potential because it has many planes of motion. And the closer you are to a physis, the better your remodeling potential is, and age matters. And then the distal, also wear in the bone is important. So you got a physis on either side in the humerus, but the distal humerus is not that good, not that active. So you wouldn't accept much deformity distally. You would accept a lot proximally because 80% of the activity comes from the proximal one. So you have to know a little bit about this. And the radius is the opposite. The distal radius has 80% of the activity, and the proximal one not so much. So you accept way more deformity here. And 20% of these ones, when you see them, are due to sporting injuries, and 1/4 of them actually have an underlying bone cyst. They're actually a pathologic fracture. And we've seen a couple of those here too. What do? Treat them the same. Let them heal. They get repetitive fractures, and you have to deal with the cyst. Last one. 15-year-old boy fell on the point of his shoulder playing American football. Severe pain, deformity, medial to the shoulder. This is a very common injury. Neurovascularly normal. Diagnosis? Clavicle. Yeah, clavicle fracture. Operation? I like to operate. I don't want to give you the impression I don't like operating. I do. And in the adult literature now, these are being operated on quite liberally based on some very small clinical differences in some randomized controlled trials. But in children, we don't have that evidence, and in fact, they reliably heal. The incidence of non-union is almost non-existent, and 6 weeks after injury, they can pretty well get back to their full sport. When they're non-tender and they've showed good radiographic healing, then they can go. The only reason we would do an open reduction internal fixation if there's neurovascular compromise, if it's an open fracture, or if, like this guy, even that guy is not really bad enough, but if it's tenting the skin and the skin is white and it's about to break down, that's an indication. But these lumps, I tell the guys back home, and I've told here now too, that if you don't have a bump on your clavicle, you're probably not playing hard enough. So wear it like a badge of honor, and it's much better than a big splash, isn't it? So they like that. So sports injuries in children are most commonly fractures. Many do well with conservative treatment alone, and if you have a physeal fracture, if they're high risk, monitor them closely. The history can help you. Return to sport, like a lot of things, depends on fracture healing and also their strength. So when you have a lack of tenderness and pain, when they get their strength back to at least 80% pre-injury, reduce the risk of other injuries, and make sure you tell them about the risk of refracture. And there are some nuances of some of these injuries which require a little bit of knowledge and remembering. Thank you very much.